Reflex testing does not require a separate clinician order for each case and may help ensure expedited and consistent routing of specimens for molecular testing. Furthermore, reflex testing is desirable because eventually most lung cancer patients will require mutation information at some point during their treatment, and then that information is available. I believe that we need to look at other cancers in order to learn from them because the ideas are not that different from that in lung cancer. When we look at breast cancer, for example, there were a few decades of lead-in and lessons in terms of predictive markers of response to drugs that we can study and apply to lung cancer. Reflex testing for estrogen, progesterone receptor, and human epidermal growth factor receptor 2, or HER2, has been the standard of care in breast cancer for some time. As such, great efforts are made to ensure the accuracy, quality, and turnaround time for these tests, and these parameters are carefully regulated by Cancer Care Ontario. We aim to make reflex testing for non-small cell lung cancer as natural as mutation testing in patients with breast cancer. Mutation testing in lung cancer should never be the exception, it should be the rule, just as it is in breast cancer. A multidisciplinary approach is just as essential here as in other areas of complex cancer care. The most important thing is to have someone in the pathology lab, usually a pathologist, and someone on the clinical side work together. In reflex testing, it is important that there is good communication between different specialists. The pathologist is often the one making the decision of when to do the test and organizing the testing, and ensuring an accurate flow of information back to the clinicians. The pathologist also has some other important jobs. One job is deciding how the tissue should be triaged to answer some questions about the tumor. Questions are, is it malignant? Is it non-small cell? Is it EGFR positive, etc.? Steps must be taken to avoid tests that would unnecessarily use up small tissue biopsies. As an example, in the case of a clear adenocarcinoma, a positive thyroid transcription factor 1 or TTF1 stain is sufficient before sending the tissue off for EGFR testing. Furthermore, it is important that the referring pathologist send the tissue for sequencing as long as they are able to identify that it is malignant and non-small cell. Most of the time, the testing lab can provide an accurate answer of this question with relatively small amounts of tissue. This will become especially true as we move into an area of next-generation sequencing. Our goal is to avoid unnecessary rebiopsies, which can be quite invasive and carry substantial morbidities. In terms of tissue procurement, 3 specialists are involved: interventional radiologist, pulmonologist or respirologist, and thoracic surgeons. Radiologists and pulmonologists have to get an adequate amount of tissue in the right format for mutation testing. For cytologic samples from radiologists or pulmonologists, a cell block is very useful, whereas smears are usually of less use in mutation testing. These specialists have to make sure that the collected sample is appropriate not only for tumor identification and for staging, but also for mutation testing. For example, bony tissue is usually not appropriate for mutation testing. In my experience, I have seen a great multidisciplinary collaboration resulting in successful outcomes for these tests. Given the complex organization of any hospital, simplicity, ease, and uniformity are important. Busy hospital employees tend to give up on things that are too complicated or involve too much paperwork and bureaucracy. The more uniform the approach, and that is why I advocate reflex testing, the more likely it is that you are going to get things done. One simple and straightforward method for ordering tested is the use of obligatory synoptic reports. These are like advanced drop-down lists that require the pathologist to fill in information about various aspects of a tumor diagnosis, including mutation status, before they can actually complete and sign out the case. Another good practice is to organize the testing so that the pathologist can order it through one click in their lab information system, reducing ordering time to about 30 seconds. This approach has already been implemented at some Ontario hospitals. Lastly, here at North York General, we are exploring a new approach in which we remotely access the originator's LIS and enter test results. This means that we do not have to fax the results and they do not have to retype them. It's amazing how much hospital information is sent by fax. Who uses faxes anymore? This way, if the mutation testing lab can put the report directly into the original institution's lab information system, errors are eliminated and reporting happens on the same day.